Training requirements. Appendix PP, Regulation Section 483.95, tags F940 through F949. Begin reading. Tag F940. Section 483.9, 5. Training requirements. A facility must develop, implement, and maintain an effective training program for all new and existing staff, individuals providing services under a contractual arrangement, and volunteers consistent with their expected roles. A facility must determine the amount and types of training necessary based on a facility assessment, as specified at Section 483.71. Training topics must include, but are not limited to, intent. Facilities are required to develop, implement, and maintain an effective training program. For all staff, appropriately trained staff can improve resident safety, create a more person-centered environment, and reduce the number of adverse events or other resident complications. CMS recognizes that training needs are likely to change over time. Therefore, it is necessary for facilities to have the flexibility to determine training needs based on its facility assessment, competencies and skill sets for all new and existing staff, individuals providing services under a contractual arrangement, and volunteers must be consistent with their expected roles. All facility staff needs to be trained to be able to interact in a manner that enhances the residents' quality of life and quality of care, and that they can demonstrate competency in the topic areas of the training program. The facility is also expected to keep a record of these trainings. Training requirements should be met prior to staff and volunteers independently providing services to residents, annually and as necessary based on the facility assessment. See Section 483.7, 1A 2 Roman 4. CMS does not propose a specific training mechanism to meet the training requirements. Regulation, and the regulation does not specify that a member of the facility must conduct the training activities. Facilities have the flexibility to work with outside entities to provide facilitated training, computer-based training, self-directed learning, mentoring, and or coaching. CMS encourages facilities to leverage community resources to assist with developing training programs, identifying qualified instructors, identifying training materials, and implementing facility training programs. Based upon the outcome of a facility assessment, suggestions for additional training topics may include, but are not limited to, advanced care planning, cultural competence, end-of-life care, geriatrics and gerontology, i.e., understanding of how human beings change as they grow older, substance abuse, working with young and middle-aged adults, grief and loss, interdisciplinary collaboration, person-centered care, specialized rehabilitative therapy, trauma-informed care, intellectual disability, mental disorder, and quality of life and care. There are various free online training tools and resources that facilities can use to assist them in complying with this requirement. For example, the Agency for Healthcare Research and Quality, ARC, released a set of training modules to help educate LTC facility staff on key patient safety concepts to improve the safety of LTC facility residents. See http://www.gov/professionals/systems/long-term care/resources/facilities/PETSAFETY/ Long-term care ombudsman can provide in-service trainings to facility staff on a variety of topics, in addition to the web-based materials, instructor and student handbooks can be sent to facilities at no additional cost. For the purposes of this training requirement, staff includes all facility staff, direct and indirect care functions, contracted staff, and volunteers training topics as appropriate to role. Note, References to non-U.S. Department of Health and Human Services HHS. Sources or sites on the Internet are provided as a service and do not constitute or imply endorsement of these organizations or their programs by CMS. CMS is not responsible for the content of pages found at these sites. URL addresses were current as of the date of this publication. Surveyors need to consider the facility's compliance for all training requirements at Section 483.95. F940 would be cited as a result of the facility's failure to implement trainings for multiple training topics included at Section 483.95. Tag F941. Section 483.95. Training requirements. Training topics must include, but are not limited to, Section 483.9. 5A. Communication. A facility must include effective communications as mandatory training for direct care staff. Definitions. Communications include services such as teletypewriter TTY and telecommunications device for the deaf TDD, use of devices such as cellular, telephones, and accessibility such as reasonable access and privacy for electronic communications like email or internet-based interpersonal video communications. C. 483.10G67. Direct care staff are those individuals who, through interpersonal contact with residents or resident care management, provide care and services to allow residents to attain or maintain the highest practicable physical, mental, and psychosocial well-being. Effective communications describe a process of dialogue between individuals. The skills include speaking to others in a way they can understand and active listening, and observation of verbal and nonverbal cues, understanding what the resident is trying to communicate is essential to giving a response. Additionally, effective communication ensures that information provided to the resident is provided in a form and manner that the resident can access and understand, including in a language that the resident can understand. See 483.10G3. Intent. We did not propose to require a specific amount of time, specific communications topics, or specific training mechanisms to meet this requirement. The topics for training should reflect the needs of the resident population and the needs of staff. These needs should correspond with the facility assessment. We expect training activities will encourage participation and allow for open dialogue among participants in order to be productive. Facilities must inform residents in a language they can understand of their total health status and to provide notice of rights and services, both orally and in writing in a language the resident understands. See Section 483.10, Resident Rights. For the purposes of this training requirement, staff includes all staff providing direct care services training topics as appropriate to role. Guidance. Recommended methods of effective communication include, but are not limited to, the following. 1. Identify yourself and use the resident's name each time you speak with them. 2. Use the proper names for people, places, and objects. Avoid saying he, she, it, or they so that the resident can understand. 3. Allow extra time. Many nursing home residents have conditions which require longer information processing time. 4. Avoid distractions and maintain eye contact if culturally appropriate. Focus on the resident. Make each interaction quality time. 5. Listen carefully to the resident's responses and directly respond to the questions and concerns. Give residents an opportunity to ask questions and express themselves. 6. Sit face to face. Residents may have vision and hearing loss, and reading your lips may be crucial. Even if the resident uses a hearing aid, it can be difficult for the resident to understand you because a hearing aid amplifies all sounds, including background noise. 7. Speak slowly, clearly, and in a normal tone, and use short, simple words. No medical or slang jargon. 8. Maintain a positive attitude, including a pleasant tone of voice and facial expression. Residents with dementia respond to the feelings you convey more than the actual words. 9. If the communication form is written, simplify the questions and stick to one topic at a time. Frequently summarize the most important points. 10. Be aware of a resident's body language communications. 11. Eliminate assumptions. Make adjustments to the communication method as required during a conversation. 12. Visual aids may be required as communication methods. 13. Repeat back what the person has said to make sure that you understand. Ask for clarification if you aren't sure what the person means. Training resource. Getting the facts. Effective communication with elders support materials. https://pog.org/site/default/files/commune support mat PDF. Mental illness. https://www.mentalhealth.gov/talk. https://www.nami.org/find support/family members and caregivers/maintaining a healthy relationship. Note, references to non-U.S. Department of Health and Human Services (HHS) sources or sites on the Internet are provided as a service and do not constitute or imply endorsement of these organizations or their programs by CMS. CMS is not responsible for the content of pages found at these sites. URL addresses were current as of the date of this publication. Probes. If there is a concern about effective communication, utilize interviews and review of training records to determine the following. Does the facility provide ongoing in-service training as necessary for permanent, temporary, and volunteer direct care staff to improve their ability to communicate effectively? Does the facility admit and care for residents that do not use the English language? How does the facility assessment reflect the need for direct care staff training? Related to communication with residents who do not speak English, what communication tools are provided, and how are staff educated about using those tools? Does the facility have alternative means of communication for residents in need? Who require them, and how are staff educated about using them, e.g. communication boards? How are ethnic and cultural differences reflected in communications? How well do permanent and temporary direct care staff and volunteers communicate with residents? Does the facility have a process in place to communicate with residents, including those with a language/communication barriers during an emergency? How does the facility train direct care staff on identifying resident nonverbal communication? How does the facility train direct care staff on identifying and understanding their own nonverbal communication? Tag F942. Section 483.9. 5. Training requirements. Training topics must include, but are not limited to, Section 483.9. 5b. Residents' rights and facility responsibilities. A facility must ensure that staff members are educated on the rights of the resident and the responsibilities of a facility to properly care for its residents as set forth at Section 483.10, respectively. Intent: to ensure all facility staff understand and foster the rights of every nursing home resident. For the purposes of this training requirement, staff includes all facility staff, direct and indirect care functions, contracted staff, and volunteers. Training topics as appropriate to role. Guidance section 483.9 5b. Facilities must develop and implement an ongoing education program on all resident rights and facility responsibilities for caring of residents, as outlined in Section 483.10. The education program should support current scope and standards of practice through curricula which incorporate learning objectives, performance standards, and evaluation criteria. Staff performance assessments should evaluate the ability to integrate knowledge and skills specific to the requirements at Section 483.10. There should be a process in place to validate that training was completed, whether in a group setting or on an individual basis. If concerns with staff knowledge and understanding of resident rights and facility responsibilities are identified by the survey team, the following probes should be utilized. In interview, observation and record review to help determine compliance with F942. Interview staff to determine if they've received training regarding the rights of residents and facility responsibilities. Observe staff interactions with residents. Review training documentation provided by the facility related to resident rights and facility responsibilities. Interview staff from various departments and disciplines about their knowledge of resident rights and facility responsibilities. Tag F943. Section 483.9, 5C Abuse, Neglect, and Exploitation. In addition to the freedom from abuse, neglect, and exploitation requirements in 483.12, facilities must also provide training to their staff that at a minimum educates staff on Section 483.9, 5C1 activities that constitute abuse, neglect, exploitation, and misappropriation of resident property, as set forth at Section 483.12. Section 483.9, 5C2 procedures for reporting incidents of abuse, neglect, exploitation, or the misappropriation of resident property. Section 483.9, 5C3 dementia management and resident abuse prevention. Definition section 483.9, 5C. Staff includes for the purposes of the training guidance, all facility staff, direct and indirect care and auxiliary functions contractors, and volunteers. Guidance section 483.9, 5C. All facilities must develop, implement, and permanently maintain an effective training program for all staff, which includes, at a minimum, training on abuse, neglect, exploitation, misappropriation of resident property, and dementia management that is appropriate and effective, as determined by staff need, and the facility assessment as specified at Section 483.71. Changes to the facility's resident population, staff turnover, the facility's physical environment, and modifications to the facility assessment may necessitate ongoing revisions to the facility's training program. There are a variety of methods that could be used to provide training. For example, staff training may be facilitated through any combination of in-person instruction, webinars, and / or supervised practical training hours. Supervised practical training means training in a setting in which instruction and oversight are provided by a person who has relevant education and / or experience specific to the subject of the training being provided. All training should support current scope and standards of practice through curricula, which detail learning objectives, performance standards and evaluation criteria, and addresses potential risks to residents, staff, and volunteers if procedures are not followed. There should be a process in place to track staff participation in the required trainings. The facility must provide staff orientation and training on the prohibition of all forms of abuse, neglect, and exploitation prohibition, The training must address forms of abuse, neglect, misappropriation of resident property, exploitation, and dementia management. Such training would include, but is not limited to, identifying how person-centered thinking, planning, and practice skills contribute to a facility culture of prevention and identification of abuse, neglect, and exploitation. Identifying and preventing behavior constituting abuse, including injuries from an unknown source, neglect, exploitation, and misappropriation of resident property. Identifying physical or psychosocial indicators of abuse, including injuries from an unknown source, neglect, exploitation, and misappropriation of resident property from situations which include, but are not limited to, verbal, mental, sexual, or physical abuse. Taking or using photographs or recordings of residents in a demeaning or humiliating manner and sharing them in any manner, including through the use of technology or social media. Theft of a resident's personal belongings. Involuntary seclusion of a resident. Exploitation of a resident, and neglect of a resident, as demonstrated by a pattern of willfully failing to provide care to a residentess. Facility procedures and federal and state requirements for reporting abuse, neglect, exploitation, and misappropriation of resident property, including injuries of unknown sources, timeframes for reporting, and to whom staff and others must report their knowledge related to any alleged violation without fear of retaliation. Reporting reasonable suspicion of a crime against a resident. Educating staff on factors related to dementia care and abuse prevention, such as understanding that expressions or indications of distress of residents with dementia are often attempts to communicate an unmet need, discomfort, or thoughts that they can no longer articulate with words. However, they may be perceived as challenging behaviors to staff and could increase the risk of resident abuse and neglect. Expressions or indications of distress can include, but are not limited to, aggressiveness, wandering or elopement, agitation, yelling out, or delusions. Conflict resolution and anger management skills, including resolving conflicts between staff and residents, visitor and resident-to-resident conflicts, and identifying and addressing factors that may precipitate abuse/neglect/exploitation, including, but not limited to, signs of staff burnout, frustration, and stress, staff prejudices to age, culture, race, religion, and sexual orientation, gender differences, and negative attitudes toward working with individuals with disabilities. While not required, sources of training materials that facilities may want to consider include National Center on Elder Abuse, online, available, https://ncacl.gov. University of Southern California, training resources on elder abuse, available, http://trioskedu/. References to non-CMS, non-governmental sources do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services, and were current as of the date of this publication. Probes Section 483.9, 5C. If there is a concern that a resident was abused, neglected, or exploited, interview staff and review training records to determine the following. Was staff observed working with residents in a manner that indicates a training need? Did interviews with residents and or resident representatives indicate any areas where training was needed? What type of training do the staff report receiving about the concern identified by the surveyor? What process does the facility have to encourage staff to express concerns and request training in challenging situations. How does the facility respond to staff's concerns and requests? Review the training coursework to determine if the content meets professional standards/guidelines and covers relevant facility policy and procedures. How does the facility's abuse, neglect, and exploitation training program ensure staff are instructed to meet the requirements of Section 483.1 to be develop/implement abuse/neglect, etc. Policies, tag F607. How does the facility's policies reflect staff training is in compliance with Section 483.12 and Section 483.12A1, freedom from abuse, neglect, and exploitation, tag F600. Verify that the facility has a mandatory requirement that all facility staff participate in an abuse, neglect, and exploitation prevention and dementia management training program with a process in place to track attendance. How does the facility determine when training content requires updating to be consistent with current professional standards and federal and state regulations? How does the facility assess staff to determine if the training has been effective? Potential additional tags for investigation. For concerns related to the development and implementation of written policies and procedures, that includes training related to abuse, neglect, exploitation, and misappropriation of resident property. See 42 CFR Section 483.1 2B3, develop/implement abuse/neglect, etc. Policies, tag F607. For concerns related to the reporting of a crime, see 42 CFR Section 483.1 2B5, reporting of reasonable suspicion of a crime, tag F609. Tag F944. Section 483.9, 5D Quality Assurance and Performance Improvement. A facility must include, as part of its CAPI program, mandatory training that outlines and informs staff of the elements and goals of the facility's CAPI program, as set forth at Section 483.75. Definitions. Quality Assurance and Performance Improvement CAPI is the coordinated application of two mutually reinforcing aspects of a quality management system, quality assurance CA and performance improvement PI. CAPI takes a systematic, interdisciplinary, comprehensive, and data-driven approach to maintaining and improving safety and quality in nursing homes while involving residents and families in practical and creative problem-solving. https://www.cms.gov/medicare/provider enrollment and certifications/CAPI/CAPI definition. Access 12/18/2020. Guidance. For the purpose of this guidance, the term staff includes all new and existing facility staff with direct and indirect care functions, individuals providing services under a contractual arrangement, and volunteers consistent with the volunteers' expected roles. See requirements in Section 483.95. Facilities must conduct mandatory training for all staff on the facility's CAPI program. That includes the goals and various elements of the program. It should also include how the facility intends to implement the program. The training should also include the staff's role in the facility's CAPI program and how to communicate concerns, problems, or opportunities for improvement to the facility's QAA committee. As updates are made to the facility's CAPI program or goals, the facility's training should also be updated and staff trained on the updates as appropriate. All training should support current scope and standards of practice through curricula, which detail learning objectives, performance standards, and evaluation criteria. There should be a process in place to track staff participation in the required trainings. Probes. Verify that the facility has a mandatory requirement that all staff receive CAPI. Training. Does the facility have a method for verifying staff attendance at the mandatory CAPI training? If so, do these records confirm that staff attended the mandatory CAPI training? Does the facility's training program inform staff of the current elements and goals of the facility's CAPI program? Are staff aware of what the facility's CAPI program entails and how the facility intends to implement and monitor their program? Are staff aware of how to bring ideas or concerns to the attention of the QAA committee? How does the facility determine when training content requires updating to be consistent with current professional standards and guidelines? It is not required to have an outcome deficiency cited for this tag to be cited for deficient staff training. If CAPI deficiencies are identified, refer to Section 483.75 for citation authority. Potential tags for additional investigation. F940, 5F 868 for concerns related to the facility's CAPI program. Tag F945. Section 483.9, 5E Infection Control. A facility must include, as part of its infection prevention and control program, mandatory training that includes the written standards, policies, and procedures for the program as described at Section 483.80A2. Guidance Section 483.95E. All facilities must develop, implement, and permanently maintain an effective training program for all staff, which includes training on the standards, policies, and procedures for the infection prevention and control program as described at Section 483.80A2, that is, appropriate and effective and as determined by staff need. For the purposes of this training requirement, staff includes all facility staff direct and indirect care functions, contracted staff, and volunteers training topics as appropriate to role. Changes to the facility's resident population, community infection risk, national standards, staff turnover, the facility's physical environment, or facility assessment may necessitate ongoing revisions to the facility's training program for infection prevention and control. All training should support current scope and standards of practice through curricula, which detail learning objectives, performance standards, evaluation criteria, and addresses potential risks to residents, staff, and volunteers if procedures are not followed. There should be a process in place to track staff participation in and understanding of the required training. Such infection control training must, at a minimum, include the following areas as described in Section 483.80A2. The facility's surveillance system designed to identify possible communicable diseases or infections before they can spread to other persons in the facility. When and to whom possible incidents of communicable disease or infections in the facility should be reported. How and when to use standard precautions, including proper hand hygiene practices and environmental cleaning and disinfection practices. How and when to use transmission-based precautions for a resident, including but not limited to the type and its duration of use depending upon the infectious agent or organism involved. Occupational health policies, including the circumstances under which the facility must enforce work restrictions and when to self-report illness or exposures to potentially infectious materials, see 483.80A2V, and proper infection prevention and control practices when performing resident care activities as it pertains to particular staff roles, responsibilities, and situations. Please refer to F980 for a detailed description of these topics. Probes Section 483.95e. If there is a concern about infection prevention and control practices or healthcare associated infections in the facility F940, interview staff and review training records to determine the following. Did staff observations or did interviews with residents and/or resident representatives indicate a training need? Did staff report not receiving training about the concern identified by the surveyor? What process does the facility have to encourage staff to express concerns and request training in challenging situations? Does the facility respond to staff's concerns and requests for training? Review the training coursework to determine if the content meets professional standards/guidelines and covers facility policy and procedures for infection prevention and control. Does the facility implement the training program and ensure staff are instructed to meet the requirements of Section 483.80A2, Infection Control, F980? Verify that the facility has a mandatory requirement that all facility staff participate in infection prevention and control training with a process in place to track such participation. Potential additional tags for investigation. For concerns related to infection prevention and control practices, see 42 CFR Section 483.80. Infection Control, Tag F980. Tag F946. Section 483.9, 5F Compliance and Ethics. The operating organization for each facility must include as part of its compliance and ethics program as set forth at Section 483.85. Section 483.9, 5F1, an effective way to communicate the program's standards, policies, and procedures through a training program or in another practical manner which explains the requirements under the program. Section 483.9, 5F2 Annual Training, if the operating organization operates 5 or more facilities. Definition. For the purpose of this guidance, the term staff includes all new and existing staff, direct and indirect care functions, individuals providing services under a contractual arrangement, and volunteers consistent with the volunteer's expected roles. See requirements in Section 483.95. Guidance Section 483.95F. The operating organization, the individual or entity that operates a facility, must provide a training program or another practical manner to effectively communicate the standards, policies, and procedures of the compliance and ethics program to its entire staff. For the operating organizations that operate 5 or more facilities, annual training for staff on the compliance and ethic program must be conducted. All training should support current scope and standards of practice through curricula, which detail learning objectives, performance standards, and evaluation criteria. There should be a process in place to track staff participation in the required trainings. Probes Section 483.9, 5F. Does the facility provide training or effectively communicate, in some manner, the facility's standards, policies, and procedures of the compliance and ethics program? Does the facility have a system in place to track staff attendance at required trainings? For organizations with 5 or more facilities, determine if annual compliance and ethics training is provided. Tag F947. Section 483.9, 5, Training Requirements. Training topics must include, but are not limited to, Section 483.9, 5G, required in-service training for nurse aides. In-service training must, Section 483.9, 5G1, be sufficient to ensure the continuing competence of nurse aides, but must be no less than 12 hours per year. Section 483.9, 5G2 include dementia management training and resident abuse prevention. Training. Section 483.9, 5G3 address areas of weakness as determined in nurse aides' performance. Reviews and facility assessment at Section 483.71 and may address the special needs of residents as determined by the facility staff. Section 483.9, 5G4 for nurse aides providing services to individuals with cognitive impairments also address the care of the cognitively impaired. Definitions. A nurse aide is defined in Section 483.5 as any individual providing nursing or nursing-related services to residents in a facility. This term may also include an individual who provides these services through an agency or under a contract with the facility, but is not a licensed health professional, a registered dietitian, or someone who volunteers to provide such services without pay. Nurse aides do not include those individuals who furnish services to residents only as paid feeding assistants, as defined in Section 488.301. Private duty nurse aides, who are not employed or utilized by the facility on a contract, per diem, leased, or other basis, do not come under the nurse aide training provision and, therefore, are not required to take the training. Performance reviews, the process used to evaluate the performance of staff on a periodic basis, which may be annually. Note, see tag F940 section 483.3, 5D7, related to the conduct of performance reviews for every nurse aide at least once every 12 months. Guidance section 483.9, 5G. All facilities must develop, implement, and permanently maintain an in-service training program for nurse aides that is appropriate and effective, as determined by nurse aide. Performance reviews see Section 483.3, 5D7, and the facility assessment as specified at Section 483.71. Changes to the facility's resident population, the facility's physical environment, staff turnover, and modifications to the facility assessment may necessitate ongoing revisions to the facility's training program. There are a variety of methods that could be used to provide training. For example, nurse aide training may be facilitated through any combination of in-person instruction. Webinars, though, should not be webinars alone in / or supervised practical training hours, and should be reflective of nurse aides' performance reviews in order to address identified weaknesses. When able, each nurse aide should be evaluated based on individual performance, and the facility should develop training that can be utilized and beneficial to all nurse aide staff when applicable. Supervised practical training means training in a setting in which instruction and oversight are provided by a person who has relevant education and / or experience specific to the subject of the training being provided. All training should support current scope and standards of practice through curricula, which detail learning objectives, performance standards, and evaluation criteria, and addresses potential risks to residents, staff, and volunteers if procedures are not followed. There should be a process in place to track nurse aide participation in the required trainings. The adequacy of the in-service education program may be measured not only by documentation of hours of completed in-service education, but also by demonstrated competencies of nurse aide staff through written exam and / or in consistently applying the interventions necessary to meet residents' needs as identified in the facility assessment. Observations of nurse aides that indicate deficiencies in their nurse aide skills may be the result of an inadequate training program and / or inadequate performance review. A minimum of 12 hours of nurse aid training per year is required under Section 483.95G1. The training must be sufficient to ensure the continuing competence of the nurse aides, which may require more than 12 hours of training per year to meet identified staff. Resident needs. The survey team does not need to find a negative outcome to cite a deficiency at F947. Procedures and Probes Section 483.9, 5G. If there have been deficient care practices identified during the survey, review as appropriate training received by nurse aides in that corresponding subject area, if there is a concern about required in-service training for nurse aides, interview staff and review training records to determine the following. Were nurse aides observed working with residents in a manner that indicates a training need? Did interviews with residents and or resident representatives indicate any areas where training was needed? What type of training do the nurse aides report receiving about the concern identified by the surveyor? Verify the mandatory nurse aid in service program is no less than 12 hours per year. Review facility training records, which supports mandatory nurse aid attendance. How has in-service education addressed any areas of weakness identified in performance reviews and any special resident needs or needs of residents with cognitive impairments? How does the facility evaluate nurse aid performance to determine what topics must be included in in-service training to address areas of weakness? How does the facility determine when training content must be updated, e.g., in order to remain consistent with current professional standards and guidelines? What process does the facility have to encourage nurse aides to express concerns and request training in challenging situations? How does the facility respond to nurse aides' concerns and requests? Does the facility's training address nurse aid training needs to ensure residents attain or maintain the highest practicable physical, mental, and psychosocial well-being as determined by resident assessments and individual plans of care? How does the facility assess nurse aides to determine if the training has been effective? Potential tags for additional investigation. For concerns related to nurse aides not demonstrating competent care of a resident that is independent of or related to the training program, see 42 CFR Section 483.3, 5C proficiency of nurse aides, tag F726 for guidance. Tag F948. Section 483.9, 5H required training of feeding assistants. A facility must not use any individual working in the facility as a paid feeding assistant unless that individual has successfully completed a state-approved training program for feeding assistants as specified in Section 483.160. Definition Section 483.9, 5H. Paid feeding assistant is defined in the regulation at 42 CFR 488.301 as an individual who meets the requirements specified in Section 483.60H1 of this chapter and who is paid to feed residents by a facility or who is used under an arrangement with another agency or organization. Guidance Section 483.9, 5H. A state-approved training course for paid feeding assistants must include, at a minimum, 8 hours of training in the following: feeding techniques, assistance with feeding and hydration, communication and interpersonal skills, appropriate responses to resident behavior, safety and emergency procedures, including the Heimlich maneuver, infection control, resident rights, recognizing changes in residents that are inconsistent with their normal behavior, and the importance of reporting those changes to the supervisory nurse. A facility must maintain a record of all individuals used by the facility as feeding assistants who have successfully completed the training course for paid feeding assistants. Probes Section 483.9, 5H. Were paid feeding assistants observed working with residents in a manner that indicates a training need? Did interviews with residents and/or resident representatives indicate any areas where training was needed? What type of training do the paid feeding assistants report receiving about the concern or deficient practice identified by the surveyor? If the facility is using paid feeding assistants and the residents requiring assistance with eating are determined to have avoidable negative nutritional outcomes, request proof that the paid feeding assistants successfully completed a state-approved training program. Tag 948 is only to be cited if it is determined the paid feeding assistantess has not completed a state-approved training program as specified in Section 483.160. It is not required to have an outcome deficiency cited for this tag to be cited related to staff training. Potential tags for additional investigation. If concerns related to the performance of the paid feeding assistant are identified, see 42. CFR Section 483.60H Paid Feeding Assistance, Tag F811 for guidance. Tag F949. Section 483.9, 5, Training Requirements. Training topics must include, but are not limited to, Section 483.9, 5I Behavioral Health. A facility must provide behavioral health training consistent with the requirements at Section 483.40 and as determined by the facility assessment at Section 483.71. Guidance Section 483.9, 5I. All facilities must develop, implement, and maintain an effective training program for all staff, which includes, at a minimum, training on behavioral health care and services, consistent with Section 483.40 that is appropriate and effective, as determined by staff need, and the facility assessment as specified at Section 483.71 for the purposes of this training. Requirement: staff includes all facility staff, direct and indirect care functions, contracted staff, and volunteers training topics as appropriate to role. Changes to the facility's resident population, staff turnover, the facility's physical environment, and modifications to the facility assessment may require ongoing revisions to the facility's training program. There are a variety of available methods to provide training, including in-person instruction, webinars, and / or supervised practical training. Supervised practical training means training in a setting in which instruction and oversight are provided by a person who has relevant education and / or experience specific to the subject of the training being provided. All training should support current scope and standards of practice through curricula, which detail learning objectives, performance standards, and evaluation criteria. There should be a process in place to track staff participation in the required trainings. A behavioral health training course, as determined by the facility assessment, should include, at a minimum, the competencies and skills necessary to provide the following: person-centered care and services that reflect the resident's goals for care, interpersonal communication that promotes mental and psychosocial well-being, meaningful activities which promote engagement and positive meaningful relationships, an environment and atmosphere that is conducive to mental and psychosocial well-being, individualized, non-pharmacological approaches to care specific to the individual needs of residents that are diagnosed with a mental, psychosocial, or substance use disorder, a history of trauma and / or post-traumatic stress disorder or other behavioral health condition, and care specific to the individual needs of residents that are diagnosed with dementia. CMS Hand in Hand, a training series for nursing homes, is an example of training that addresses this area. Probes Section 483.9, 5I. If there is a concern that the behavioral health needs of residents are not being met, utilize observations, interviews, and review of training records to determine the following. Does staff demonstrate the skills needed to promote the highest practicable level of functioning for residents with identified behavioral health care needs? Can staff explain concepts learned in training? How does the facility assure that all staff interacting with residents are trained as required? This may include nursing, therapy, activity, housekeeping, dietary staff, and others as needed. How does the facility assure that all facility staff, contractors, and volunteers are trained to interact with those residents with specific behavioral health care needs? Is the training program designed to address the residents' specific behavioral health care needs? How does the facility keep track of staff participation in required training? How does the facility monitor the effectiveness of the training program? How are changes implemented to the training program if desired outcomes are not achieved? Is the training curriculum based on the results of the facility assessment required? At 483.71, transmittals issued for this appendix. Rev hash issue date, subject impl date CR hash. R211, Psalm 02/03/2023, 10/24/2022, and /A. Revisions to State Operations Manual. Psalm Appendix PP. R208, SOM 10/21/2022, Revisions to State Operation Manual. Psalm 10/24/2022 and /A. R207, SOM 09/30/2022, Appendix PP Guidance to Surveyors for R173, SOM 11/22/2017 Long-Term Care Facilities. R168, Psalm 03/08/2017. Revisions to State Operation Manual. Psalm 10/01/2022 and /A. R167, SOM 02/10/2017 Appendix PP Guidance to Surveyors for Long-Term Care Facilities. R157, Psalm 06/10/2016. R149, SOM 10/09/2015 Revisions to State Operation Manual. Psalm 11/28/2017 and /A. R133, SOM 02/06/2015 Appendix PP Guidance to Surveyors for R130 SOM 12/12/2014 Long-Term Care Facilities. R127, Psalm 11/26/2014. R107, SOM 04/04/2014 Revision to State Operations Manual. Psalm 03/08/2017 and /A. Appendix PP Incorporate Revised. Requirements of Participation for Medicare and Medicaid Certified Nursing Facilities. Revision to State Operations Manual. Psalm 02/10/2017 and /A. Appendix PP Incorporate Revised. Requirements of Participation for Medicare and Medicaid Certified Nursing Facilities. Rescinded and replaced by Transmittal 168. Revisions to the State Operations Manual 06/10/2016 and /A. Psalm Appendix PP Guidance to Surveyors for Long-Term Care Facilities. State Operations Manual SOM for all 10/09/2015 and/A. Types of providers and suppliers subject to certification. Revisions to State Operations Manual 02/06/2015 and/A. SOM Appendix PP Guidance to surveyors for long-term care facilities. Revisions to State Operations Manual 12/12/2014 and/A. SOM Appendix PP Guidance to surveyors for long-term care facilities. Revisions to State Operations Manual 11/26/2014 and/A. SOM Appendix PP Guidance to surveyors for long-term care facilities. State Operations Manual SOM Appendix 04/04/2014 and/A. PP LTCF Revisions for intermediate care facilities for individuals with intellectual disabilities IC/ID. R70 SOM 01/07/2011 Revisions to Appendix PP State Operations 10/01/2010 and/A. Manual SOM Guidance to Surveyors for R66 SOM 10/01/2010 Long-Term Care Facilities LTC4. Minimum Data Set MDS Implementation. R55 SOM 12/02/2009 October 1, 2010 Rescinded and replaced by R54 SOM 11/30/2009 Transmittal 70. R52 SOM 09/25/2009 Revisions to Appendix PP State Operations 10/01/2010 and/A. Manual SOM Guidance to Surveyors for R51 SOM 07/20/2009 Long-Term Care Facilities LTC4. Minimum Data Set MDS Implementation. R48 SOM 06/12/2009 October 1, 2010 Rescinded and replaced by R41 SOM 04/10/2009 Transmittal 70. R36 SOM 08/01/2008. Revisions to Appendix PP Guidelines for 09/30/2009 and/A. R26 SOM 08/17/2007 Long-Term Care Facilities Tag F940. R22 SOM 12/15/2006. R21 SOM 10/20/2006 Revisions to Appendix PP Guidelines for 09/30/2009 and/A. R19 SOM 06/01/2006 Long-Term Care Facilities Tag F941. R15 SOM 11/28/2005 Rescinded and replaced by Transmittal 55. R14 SOM 11/25/2005. R12 SOM 10/14/2005 Revisions to Appendix PP Guidelines for 09/30/2009 and/A. R08 SOM 06/28/2008 Long-Term Care Facilities Tag F941. Rescinded and replaced by Transmittal 54. Revisions to Appendix PP Guidelines for 09/30/2009 and/A. Long-Term Care Facilities Tag F941. Rescinded and replaced by Transmittal 52. Revisions to Appendix PP Guidelines for 06/12/2009 and/A. Long-Term Care Facilities. Revisions to Appendices P and PP 04/10/2009 and/A. Revisions to Appendix PP Interpretive 09/01/2008 and/A. Guidelines for long-term care facilities. Tags F925 and F971. Revised Appendix P and Appendix PPNU 08/17/2007 N/A. Tag F973. Revisions to Appendix P and PP 12/18/2006 N/A. Revised Appendix P and Appendix PPNU 10/15/2006 N/A. Tag F934. Revisions to Appendix PP 06/01/2006 N/A. Medical Director, Guidance 11/25/2005 N/A. Medical Director Guidance, replaced by 11/25/2005 N/A. Transmittal 15. Appendix PP Technical Corrections 10/14/2005 N/A. Revision of Appendix PP Section 483.2 5D06/27/2005 N/A. Urinary incontinence. Tags F915 and F916. R07 SOM 06/27/2005. Revision of Appendix PP Section 483.2 5D06/28/2005 N/A. Urinary incontinence. Tags F915 and F916. R05 SOM 11/19/2004, replaced by Transmittal 8. R04 SOM 11/12/2004. R01 SOM 05/21/2004 revisions to Appendix P and Appendix PP 11/19/2004 N/A. Guidance to Surveyors for Long-Term Care 11/12/2004 N/A. Facilities. Initial release of Pub 100 to 07 N/A. This concludes the reading of Appendix PP. Regulation Section 483.95, tags F940 through F949.